Welcome to the deep dive. We're really glad you were joining us today because we are getting into a topic that is quite literally a matter of life and death. But we are going to be looking at it through a lens you might not expect. It's this lens of extreme, high-stakes anatomical puzzle solving. Today, we are talking about pediatric liver transplants.
It is just a phenomenal field of medicine. I mean, the sheer complexity of what happens inside the operating room and really the intense mathematical planning that goes on long before the surgery even begins, it's truly astonishing. Treating a child is never just a matter of treating a miniature adult.
Right.
And that becomes incredibly clear when we look at the liver.
Exactly. And to guide us through this maze, we're looking at a brand new, highly detailed 2025 report from the AJR Special Series on Critical Anatomy. This material was put together by the Pediatric LIR-Age Working Group alongside actual pediatric liver transplant surgeons.
Yeah, top of their field.
Right. And our mission today is to take you beyond just the basic concept of organ donation. We really want to uncover the mind-blowing engineering, the 3D mapping, and the outright surgical gymnastics required when your patient is a tiny child.
The margins for error here are, well, they're measured in millimeters.
Yeah.
The diseases are completely different from what we see in older populations, and the internal anatomy of a child presents just a uniquely difficult set of geographic challenges.
Okay, let's unpack this, because that core difference between adult and pediatric patients is exactly where we need to start.
Yeah.
When you hear about adult liver transplants in the news, it's mostly for chronic issues, right? We're talking about alcohol-related liver disease or metabolic dysfunction-associated steatotic liver disease.
Correct. It's usually the result of years, sometimes decades of accumulated damage.
Right. But in kids, it's an entirely different landscape. Just to set the scene for you with some numbers from the report. In 2023, there were 534 pediatric liver transplants in the U.S., and an incredible 25% of those were performed on babies younger than 1 year old.
When you really pause to think about that statistic, it is staggering. 1 in 4 of these complex, life-saving surgeries is being performed on an infant.
Yeah.
And yet, even with those 534 procedures happening, another 404 children remained on the waiting list that exact same year.
The need is so urgent. I mean, if you were listening to this and looking at your own child or niece or nephew, it is really hard to fathom a surgery this precise happening on a body that small.
Oh, absolutely.
Which brings us to the underlying question. Why do babies need new livers in the first place?
Right.
The main culprit, which accounts for about 40% of these transplants, is a condition called biliary atresia. Now, the report describes it as a progressive, fibro-obliterative disease. Could you maybe translate that for those of us who aren't reading medical journals every day?
Of course. To put it simply, think of the liver as a massive manufacturing plant.
Okay.
And the bile ducts are the outbound plumbing pipes that carry the bile away from the liver and into the intestines.
Makes sense.
In biliary atresia, those pipes become blocked. The fibro-obliterative part basically means aggressive scarring. So imagine someone pouring concrete down the outbound plumbing of that factory.
Oh, wow.
Right. The pipes seal shut, the toxic bile backs up, and it actively destroys the liver tissue from the inside out.
That sounds awful.
It is. It's a congenital issue, meaning it presents right there in early infancy, and it moves fast.
I noticed the report mentions a procedure called the Kasai portoenterostomy as a sort of palliative bridge for these babies. What exactly are the surgeons doing there?
They are attempting a massive plumbing bypass. The surgeon removes the blocked bile ducts entirely.
Okay.
Then they take a piece of the patient's own intestine, specifically fashioning what is called a Roux-en-Y loop. Imagine taking a flexible garden hose, bringing it up, and attaching it directly to the exposed, cut surface of the liver.
Direct connection.
Exactly. The goal is to give the bile a new path to drain directly into the gut.
That is a brilliant workaround. But the data shows it's often just buying time, right? The report notes that 60 to 70% of these Kasai patients eventually need a full transplant anyway.
Yeah, unfortunately.
Because the microscopic scarring inside the liver continues, which leads to progressive cirrhosis.
What's fascinating here is that while biliary atresia is the dominant cause, the other reasons kids need transplants tell us a lot about how versatile this surgery has become.
How so?
For instance, metabolic diseases account for about 19% of these cases in the U.S.
Okay.
We are talking about genetic defects like Wilson disease, where the body can't process copper. In some of those metabolic conditions, getting a new liver is an outright cure.
Because you aren't just replacing a failing organ, you are literally swapping out the defective cellular machinery. The new organ has the correct genetics.
Precisely. The new liver produces the missing enzymes the child's body desperately needs.
That is incredible.
It really is. In other metabolic cases where the disease affects multiple systems in the body, the transplant might not be a total cure, but it is deeply disease-modifying. It improves the child's quality of life dramatically by reducing severe complications.
Right.
And then rounding out the major categories, in about 8% of cases, we see transplants happening for rare liver tumors like hepatoblastoma.
We are definitely going to get deep into the tumor side of things in a few minutes because the surgical mapping required for that is just incredible.
It's wild.
But first, let's talk about the most obvious physical challenge outlined in the report. The geometry problem.
The geometry problem, yes.
You have an infant who needs a liver. The liver is the largest solid internal organ in the human body. You cannot just put an adult whole liver into a baby.
No.
Imagine trying to fit a heavy-duty truck engine into a tiny, compact car. It simply does not fit. So how do they solve the sizing issue?
They rely on one of the most remarkable innovations in transplant medicine, technical variant grafts.
Variant graft.
Yeah. Instead of using a whole organ, surgeons use a specific anatomically defined piece of an adult liver.
Okay.
The most common segment used for infants and young children is called a left lateral section graft.
When you say section, it makes the liver sound like an orange with distinct wedges. How does a surgeon even know where one section begins and another ends?
That is actually a great analogy. The liver is functionally divided into 8 distinct zones, known as Kuno segments.
Kuno segments.
Right. Each segment has its own independent blood supply coming in and its own biliary drainage going out.
Wow, self-contained units.
Exactly. The left lateral section specifically consists of segments 2 and 3. It is the smallest functional unit of the liver that can be safely removed from a donor and transplanted into a recipient.
So where do they usually get this specific graft?
It can come from a deceased donor where one liver is quite literally split to save 2 different people, or it can come from a living donor.
The living donor liver transplant, or LDLT. The report highlights that LDLT results in superior survival rates for the child, which makes total sense.
Right.
I mean, you get a much shorter wait time and the doctors can plan a much better size match.
Absolutely.
But despite those huge advantages, LDLT only makes up about 12% of pediatric liver transplants in the United States.
Mm-hmm.
Meanwhile, the report notes that in countries like China, it accounts for up to 80% of procedures. What is causing that massive gap?
The report attributes it to a few significant barriers here in the U.S. There are socioeconomic factors that make it difficult for a living donor to take the necessary time off work for major surgery and recovery.
That makes sense.
There is also a lack of specific technical expertise at certain regional transplant centers.
Sure.
And crucially, there are strict medical concerns about the health of the potential donor's liver. It is an intense, major operation for a completely healthy person to undergo, so the medical community is exceedingly protective of those living donors.
Here's where it gets really interesting, because even when you are just taking that small left lateral section, the math has to be perfect.
It has to be flawless.
The report details the risk of what they call a large for size graft. There is a very specific mathematical threshold they cannot cross.
Right.
If the weight of the donor graft is more than 4% of the recipient's total body weight, it is considered dangerous.
And that 4% threshold is particularly critical in neonates or infants weighing less than 5 kilograms. The physiological consequences of crossing that line are severe.
So what actually happens inside the body if the graft is too big?
Well, if you force a large piece of dense tissue into a tiny abdominal cavity, you cause immense physical pressure.
Like overpacking a suitcase.
Worse, the liver's own weight and the tight space squeeze its delicate blood vessels shut. The blood perfusion drops.
Oh, wow.
You develop what is known as intra-abdominal hypertension. Essentially, the pressure inside the belly becomes so high it threatens other organs.
That is terrifying.
In extreme cases, the surgeon might reach the end of the transplant and physically be unable to close the child's abdomen without crushing the new liver.
That paints such a vivid, high-stakes picture. And you can't just trim the edges of the liver to make it fit, because you might slice right through the vital plumbing system that keeps it alive.
Exactly.
Before any surgeon picks up a scalpel, someone has to map every single vessel and duct to ensure that 4% math works out. This is where the radiologists step in.
Yes.
And reading this report, I really see them as the unsung map makers of the whole operation.
They absolutely are. The rules for evaluating a living donor rely entirely on advanced imaging things like CT scans and MRIs utilizing 3D volumetric calculations.
So they're building a digital model.
Right. First and foremost, the radiologist has to calculate the functional liver remnant, or FLR.
FLR, what is that exact?
That is the exact percentage of liver volume that will be left behind inside the living donor. For a healthy adult, they typically need an FLR of at least 30%.
Just to ensure their own liver can safely regenerate and function without sending them into liver failure.
Precisely.
And beyond the sheer volume, they also have to measure the fat content in the liver, correct? The report mentions steatosis quite a bit.
Yes. Hepatic steatosis, or a fatty liver, is the most common diffuse abnormality found in potential donors during these screenings.
Okay.
The rule of thumb is that the graft must generally have less than 30% fat.
Why is that fat percentage so critical to the success of the transplant?
Because a fatty liver doesn't handle the stress of surgery well. It doesn't regenerate as efficiently. If a surgeon transplants a graft with more than 30% steatosis, there is a significantly higher risk that the graft will function poorly or fail entirely within the first year.
That makes a lot of sense.
The radiologist uses specialized MRI techniques or non-contrast CT scans to quantify that fat fraction precisely before anyone is ever cleared for the operating room.
So, assuming the volume is safe and the liver is healthy, the radiologists then have to map the actual plumbing, the arteries, the veins, the bile ducts. And I have to say, this part of the report stunned me.
Oh, the variant anatomy?
Yes. You grow up thinking all human bodies are built the same inside, following the textbook diagrams, but we really aren't.
Not at all. The variations in human vascular anatomy are incredibly diverse.
The statistics are wild. The report states that between 25 to 50% of people have variant hepatic arteries, meaning their arterial blood supply takes a completely different route than the standard anatomical drawing. How do radiologists even communicate what they are looking at to the surgeons?
They use a standardized language called the Michaels classification system. It outlines 10 distinct variant types of arterial anatomy.
10, wow.
Yeah. A radiologist might look at a scan and tell the surgeon, this donor has a Michaels type 3 anatomy, which immediately informs the surgeon that the artery supplying the right side of the liver is originating from a completely different main vessel than usual.
And the veins are even more unpredictable. The report notes that only 39% of people have the standard pattern of 3 hepatic veins draining into the inferior vena cava.
Right.
That means the majority of the population has a variant plumbing setup.
Which is exactly why this 3D mapping is non-negotiable. If you are going to take segment 2 and 3 out of an adult and connect it to an infant, you need to know exactly where your surgical transection your cut line is going to be.
Because if you cut the wrong pipe.
Exactly. If an unexpected artery or vein crosses that planned cut line in an unusual way, it might completely exclude that person from being a donor. A single rogue vessel can force the team to abandon the strategy entirely.
It is the ultimate puzzle.
Yeah.
And speaking of complex mapping puzzles, let's transition to that 8% of pediatric patients getting transplants for liver tumors, specifically hepatoblastoma.
Yes, tumors change the game entirely.
Because if you introduce a tumor into this delicate geographic space, the planning gets exponentially more difficult.
It does. The overarching goal with a tumor is to remove the mass cleanly with negative margins.
Meaning no cancer cells are left behind at the edges.
Exactly. But you still have to preserve enough healthy plumbing for the remaining liver to survive, or you have to map out a total transplant.
To communicate the severity and location of these tumors, the medical community uses an imaging-based staging system called pretext-T. That stands for P-pre-treatment extent of tumor.
Correct.
Basically, it is a way to categorize the tumor from group I to group 4, and it relies heavily on something called Cantley's line. Can you explain what Cantley's line is for our listeners?
Sure. Imagine an invisible equator running through the liver, separating the right lobe from the left lobe.
Okay.
That is Cantley's line. The pretext grouping is determined by how many contiguous or touching sections of the liver are free of the tumor.
Got it.
For example, a group I means the tumor is confined to just one section, leaving 3 contiguous sections completely healthy.
And group 4.
A group 4 means the tumor has invaded all 4 main sections, which almost certainly necessitates a full transplant rather than just removing a piece. If we connect this to the bigger picture, the pretext Q group alone doesn't give the surgeon the full story. The radiologists also append what are called annotation factors.
Annotation factors.
These are the critical warning signs. For instance, you might see a P+ annotation, meaning the tumor is wrapping around or invading the portal vein.
Right.
Or even more daunting, a V+ annotation.
I saw the V+ annotation in the report.
Yeah.
And the surgical response to it sounds terrifying. The V stands for the inferior vena cava, right?
Yes, the IVC.
Why does that specific vein make the surgery so much harder?
The inferior vena cava is the massive central highway carrying all the deoxygenated blood from the lower half of your body back up to your heart.
Okay.
If a tumor is encasing that vein, or if a tumor thrombus, a clot made of cancer cells, has grown inside of it, the surgery becomes a monumental undertaking. To safely remove it, surgeons often have to perform total vascular isolation.
I was hoping we would cover this because total vascular isolation blew my mind. Walk us through what the surgeons are actually doing to the patient's blood flow in that scenario.
They are completely stopping the blood flow to and from the liver area.
Okay.
They place a clamp on the inflow vessels at the base of the liver. They clamp the massive vena cava below the liver.
Just totally shutting down the highway.
Exactly. And if that tumor thrombus extends high enough up the vein, they have to clamp the vena cava above the liver. In the most extreme cases, the surgeon has to place that upper clamp all the way up into the right atrium of the heart itself.
They're placing clamps inside the heart of a child just so they can safely rebuild the blood vessels down in the abdomen.
Yes.
That is borderline science fiction.
It is an incredible feat of modern medicine. And while they have the blood flow isolated, they utilize another remarkable piece of technology mentioned in the report. They use an injection of a dye called indocyanine green paired with near-infrared fluorescence cameras.
This is the part that literally makes the tumors glow in the dark, right?
Exactly. When the surgeon looks through the specialized camera, the main tumor, and more importantly, any tiny microscopic metastatic deposits hiding in the healthy tissue, fluoresce brightly.
Wow.
It allows them to visually confirm they are getting those clean margins before they unclamp the vessels and restore blood flow.
So what does this all mean when the clamping is done, the tumor is out, the new graft is in, and the child's abdomen is finally closed? Are they out of the woods?
Unfortunately, no. The immediate post-operative phase in pediatric liver transplants is fraught with specific dangers. The biological battle is really just beginning.
The most dangerous complication highlighted by the AJR report is hepatic artery thrombosis, or HAT.
Yes, HAT.
Basically, a blood clot forming in the main artery that supplies the new liver graft. The data shows that kids have a risk of developing this clot that is up to 4 times higher than adult transplant patients. Why is it so much more common in children?
It comes down to fluid dynamics and the sheer scale of the anatomy. The blood vessels the surgeons are suturing together in an infant are microscopic.
How small are we talking?
Often just a few millimeters wide. Think about the diameter of a piece of spaghetti.
Oh, wow. Yeah.
When you are pushing blood through a pipe that tiny, even a microscopic imperfection in the surgical stitch, or a slight temporary drop in the child's blood pressure can alter the flow enough to allow a clot to form.
And if that artery clots, what happens to the new liver?
It is a catastrophic event. The liver tissue itself might survive for a short time by drawing blood from the portal vein, but the biliary system, those fragile bile ducts we talked about earlier, relies almost entirely on that tiny hepatic artery for its oxygen.
Right.
If the artery clots, the bile ducts necrose. They die, and they immediately start leaking toxic bile directly into the child's abdomen.
That explains why the post-op monitoring is so intense. The report mentions they monitor these kids with Doppler ultrasounds constantly, sometimes every day or even every 8 hours, just watching the velocity of the blood flow to catch any hint of a stricture before it fully clots.
Constant vigilance is the only defense. And there is another post-operative complication that is largely unique to the technical variant grafts we spent time unpacking.
Right, because they're using a cut piece.
Exactly. Because the surgeons are using a cut piece of an adult liver, they are inevitably slicing through a very complex microscopic network of internal plumbing.
The report refers to these as excluded or orphan ducts. How does a duct become orphaned?
Think about splitting a house in half.
Okay.
If you cut straight down the middle, you are going to sever some water pipes in the walls. A whole liver has a neat, unified drainage system.
Sure.
But when you cut segment 2 and the third out, you might sever a tiny branching bile duct right along the raw cut surface of the tissue. That little duct is now separated from the main drainage system that the surgeon carefully connected to the child's intestine.
So it has nowhere to drain.
Right. It just leaks bile continuously from the cut surface, or it gets blocked up and infected, causing a condition called focal cholangitis, essentially localized inflammation and infection of the bile ducts.
How common is that?
The report notes this happens in 12 to 15% of variant grafts, compared to only 7% in whole liver transplants.
How do they fix an orphan duct if the child has already had a surgery? Do they have to open them back up?
Usually they try to avoid another massive open surgery. They rely on interventional radiologists.
Oh, the map maker's return.
Exactly. These specialists use real-time imaging to guide a needle percutaneously, meaning straight through the skin of the abdomen, to place a tiny drain directly into the blocked duct, allowing it to heal and seal itself off over time.
When you lay the entire timeline out like this, it really forces you to appreciate the incredible multidisciplinary teamwork required.
It really does.
For those listening, picture this as a seamless high-stakes relay race. It starts with the radiologist's 3D mapping and strict mathematical volumetry. Then the baton is passed to the living donor, making a massive personal sacrifice. Then to the surgeon performing microstitching and vascular reconstruction under the most intense pressure imaginable. And finally, the baton goes back to the radiologist and the ICU team with their relentless ultrasound monitoring, trying to catch clots before they destroy the graft.
It truly takes an entire hospital ecosystem working in perfect synchronization to save one child's life.
To summarize what we've covered today, pediatric liver transplants are a masterclass in extreme problem solving.
Yeah.
You are balancing incredibly tight geographic constraints inside an infant's body, utilizing strict mathematical thresholds to ensure a graft isn't large for size, and executing a high-wire act of vascular reconstruction, sometimes involving clamping up into the heart itself just to make the plumbing work.
This raises an important question, though.
Oh.
One that really makes you marvel at human biology beyond the bounds of the operating room.
Yeah.
We spend all this time utilizing advanced imaging and precise math to make a specific segment of an adult liver fit into an infant today. But how does that distinct piece of adult anatomy know how to regenerate, reshape itself, and ultimately scale perfectly over the next 2 decades to accommodate the growing body of that child into adulthood?
That is fascinating.
We understand the plumbing required to connect it, but the biological magic of how that mapped anatomy adapts for tomorrow is an entirely new frontier to explore.
That is such a wild thought to leave on. The surgeons and the math get the organ in, but biology takes the wheel for the rest of that child's life. Thank you so much for joining us on this incredibly complex and awe-inspiring deep dive into the AJR report. We hope you've gained a new appreciation for the map makers, the donors, and the surgeons who make this possible. We will catch you next time.